is being recorded.
Sorry, I just
and that's okay. I'm going to, so yeah, as Kate said, this is our last session, session 6 of our management of viral load project Echo, the first one we've tried at Anova, and thanks everyone for your support of the process. It's been a steep learning curve, but I've been really impressed with how people have managed to get used to the platform and the flow of the session. So we'll be following the same flow today. It'll be myself, and then Dr. Tumiso is going to share a case, and then we'll have a case discussion. So to kick off, I just want to do a quick poll first to see what your current understanding is of low-level viremia. So a 38-year-old male has a viral load of 127 copies. When will you repeat that viral load? And we'll just give it a minute. We know that there are 17 people on the call, so we'll try and get as many of you answering as possible. We're up to 9, 10. Thanks for taking part. Okay, so great to see that everyone who is on this call is up to date with the new guidelines. We're getting 100% marking the right answer, which is 3 months. If you want to use this poll during your presentations, then please do so, and let's see if amongst Department of Health staff everyone is also on the same page. I'm going to end the poll now and we'll move on to the presentation. Thanks for answering. So just as a little bit of background to low-level viremia, the definition of low-level viremia is a viral load between 50 and 999. And why does it matter? So there's research from the pre-dolutegravir era, so when we were mostly using the NNRTIs like nevirapine and efavirenz, and then the protease inhibitors, that showed that if people continue to have persistent low-level viremia over time, so it's always bobbling along above 50, it is a clearly identified risk factor for future virological failure and the patient rebounding above 1,000 copies and eventually developing ARV drug resistance. So that's why in the new guidelines that they've shifted from being proactive for a viral load over 1,000 to becoming proactive as soon as the viral load shows up anything above 50, and they encourage the clinician to provide early enhanced adherence counseling, repeat the viral load after 3 months. And please take note that if you're working with pregnant and breastfeeding women, you must repeat that viral load in 1 month. You don't wait for 3 months. So what is a viral blip? Because quite a lot of people speak about low-level viremia and viral blip as though they are almost interchangeable. But the important thing about a viral blip is that it's a once-off low-level viremia result. So when you repeat the viral load 3 months later, that repeat viral load is below 50 copies. The patient has resuppressed and has become undetectable. So if you have a once-off and the person then resuppresses, it's not a cause for concern. That's not going to lead to accumulating resistance or treatment failure. You can reassure the client and you can keep them in the RPC or your DMOC or your multi-month dispensing model. And that's really important because in some of the districts, we have this decision that's been made that if someone has a first viral load above 50, they don't get removed from their RPC model. You just call them back to repeat the bloods. And that's because of these blips that a lot of patients will resuppress. But there will be another group of patients who have persistent low-level viremia, who have 2 or more consecutive viral loads, which are sitting between 50 and 999. And those are really the patients that we want to be proactive with and try and get them to resuppress and become undetectable again. So Sorry. So when you have someone with a low level viremia, it's important to do your ABCD again. And one of the reasons why we put this session at the end of the program was also to use it as a refresher so that we can go over the ABCD again. So if someone has a low level viremia, it might be an early warning sign of adherence problems that aren't too serious yet, but might gradually get worse. So it's a great opportunity to review adherence, to go over treatment literacy, and to avoid that viral rebound where it climbs over 1,000. Then in terms of the B for bugs, a common cause for a low-level viremia is an or acute gastroenteritis with diarrhea or vomiting that can impact on your absorption, obviously, and then you can get unstable drug levels and you might get a little bit of replication happening. So it's really important for all these people who have the low-level viremia to screen carefully for STIs, and ask about if when they took the blood, do they remember having a flu-like illness or feeling a bit under the weather. And then if they're on other opportunistic infection treatment, let's say they're on Bactrim, they're on INH, they're on pyridoxine, and they've got a big, or treatment like TB treatment, that they've got a big pill burden, just make sure that's not impacting on their adherence. For the correct dose, it's the same as for high level viremia over 1,000, that we need to think, particularly in children, check their weight, make sure that they're on the right dose, like was covered in session 5. And then for the drug interactions, we'll go through that briefly just now, just to remind you of the common drug interactions, because a mild drug interaction may well cause a low-level viremia. But the resistance shouldn't be an issue. It's very, very unlikely that a client, even with persistent low-level viremia, has significant drug resistance. It's just that ongoing replication becomes a risk for them progressing to higher levels of viral load and eventually developing drug resistance. So I think the important take-home message is that low-level viremia is an early warning system for us that there may be adherence issues, and it's the most common cause for someone having a low-level viremia. So always take time to explain the results to the patient and to let them know that they're not undetectable, and that's not ideal. So it's not worrying in terms of disease progression. Their soldier cell CD4 count shouldn't decline, but we want to get on top of it because we don't want it to result in an increasing viral load over time. So make sure you're creating a safe space with open-ended questions that are non-judgmental to ask about adherence, and explain that these short-term wobbles in adherence, where someone might have just gone through a bit of a rough patch, maybe they lost their job, maybe there was a bereavement in the family, they've had financial stress, that's part of the lifelong treatment journey, and we're just here to support them to manage to take their meds every day and to get on top of any challenges before they get worse. If you have someone with persistent low-level viremia, ideally, they shouldn't be in that RPC or DMOC model until you get them resuppressed. But I know one of the challenges in many of our districts is that our rate of viral load above 50 is actually quite high. It's up to a quarter or 30% of our patients in some of the districts. So to take them all out of the decanting approach is challenging. But I think you do need to be careful if you've got someone whose low-level viremias are gradually creeping up, or if they're having 2, 3, 4, 5 in a row. You need to keep an eye on those patients because they might rebound. And if they're in the DMOC model, you're going to struggle to do that 3-monthly viral load monitoring. So just try and enable them to resuppress, and then they can go back into the MMD. And then many of these clients, they don't have serious adherence issues. They're just missing a dose now and then, maybe once or twice a month. And they really don't understand why that occasional missed dose is a problem. So they don't know what HIV is doing in their body. They don't know how their ARVs actually work. And they don't know what happens when they miss a dose. So they aren't understanding the implications of missing a dose here and there. So when I meet people with occasional adherence issues, I tend to go through these 3 points when I'm addressing treatment literacy. And the first is that it's not just about the HIV killing the soldier cells off. It's also about how the HIV is using those soldier cells as a little factory to make new copies. So the HIV goes into the soldier cell and takes over the soldier cell's machinery to start producing those new copies. And eventually the soldier count, the CD4 count drops because the HIV overwhelms that cell and it bursts open and dies. And all these new pieces of HIV from the factory are being released into the blood. And then they go off like fireworks and go and find other soldier cells to turn into more factories to produce more HIV. So that's what's actually happening in the body with HIV infection, is this war going on between more and more virus and less soldiers, and more of the soldiers are being turned into these factories. So when the person takes the ARV, what happens is the ARV goes to that soldier cell and it puts a lock on the factory and it turns off production. So there's no more copies being made. The soldier cells stop dying. The soldier cells can start recovering and the viral load goes down. And that's why they become undetectable, because their factories have been switched off. There's no more production. But the moment they miss even a single dose, the drug level in their blood drops below the therapeutic level, below the working level, and the lock falls off the factory and straight away it switches back on. So if your blood drug level drops too low, the factories go straight back into production, the viral load starts to go up again. And what's important is those factories, as they're producing new virus, they're not very careful, they're not very accurate, and they make all these little mistakes in the virus structure, and that's what leads to resistance. So if your drug levels are up and down and the factory is on and off, that's where the risk of resistance comes in. So one thing that's really important with these clients who have occasional missed doses is to teach them that it's better late than never. And even if they take their meds up to 6 hours late, it's better than allowing that drug level to drop to the point where the factories switch back on again. So the other issue is these short-lived infections and the flu-like illness or the upper respiratory tract infection, which is quite a common cause for a low-level viremia. And to be honest, I've never read anything to explain why, but it's widely written about that they just lose viral suppression, even if they're taking their ART well, and they get this little blip. And because after 3 months, when you repeat the viral load, the person's fully recovered from that viral infection, they should be resuppressed. So these acute short-lived infections should just lead to a blip. They shouldn't lead to persistent low-level viremia. However, when it comes to STIs, they can either cause a blip or they can cause persistent replication, because if you don't screen and pick it up and treat it, then that STI is continuing. But also importantly, if you don't reach out and contact the partner and make sure that they are treated, that patient might be getting sorted, getting treated, going out, getting reinfected, and the viral load is up and down every time you're checking it. So please, if you pick up a patient who has an STI and that's the likely cause of the low-level viremia, make sure you're doing contact tracing and treatment for their partners. And then the other issue is diarrhea and vomiting. Because it impacts on absorption, they can get a temporary low-level viremia. And I've actually got a pregnant lady who I'm dealing with at the moment, where it seems like her low-level viremia is coming from, she was on one brand of the TLD and she was fine. They moved her to another brand and she immediately reported that she was getting diarrhea daily after taking her pill. We switched her back to the other brand and she's been okay, but she had a low-level viremia while she was having that side effect from the brand. So always ask about GIT symptoms and whether it's just a once-off that it happened briefly or whether it's an issue that keeps on coming and going. And if it's coming and going over time, you need to look for why. And then hopefully you will remember this slide because we spoke about it in the third session, I think. But drug-drug interactions are another reason for low-level viremia. So go through previous or current TB treatment. Make sure if they're on TB treatment, they've got that extra dose of dolutegravir. check for comorbidities, particularly epilepsy and any anticonvulsants. Make sure if they're pregnant that you've dealt with the timing of their positive cations, the iron and the calcium. And really, really important, ask about traditional medicines and non-prescribed over-the-counter medications like your antacids and multivitamins, because so many patients don't perceive those as medications. So you ask them, are they taking any medications? They'll say no. Ask them if they suffer from heartburn. They'll say yes. What do you use for it? I take Gaviscon or Enos. Boom, there might be your reason for the low-level viremia. So take a very careful drug history. And then, as we've spoken about before in another session, there's this issue of if a couple are not using condoms regularly and the other partner may not be engaged in care, may not be virally suppressed, and that cause low-level viremia? And from all my understanding, the answer is no, unless the lack of condom use is resulting in these recurrent STIs. But don't, if you pick up from a history that a couple are not using condoms, don't then say, I found the cause for the low-level viremia. Do the STI screen, and if there's no sign or symptom of STI, you've got to keep looking for another cause of the low-level viremia, because it's not just going to be a reinfection of HIV causing the viremia. Remember what we said previously, that if 2-drug PrEP works to prevent new infections, 3-drug ART with adherence will prevent reinfection. So you shouldn't be getting a constant viremia if that client who's adherent to ART is taking it well, because it will be working basically as PrEP as well. And then you might have noticed in the guidelines that they do say that if someone has a low-level viremia or a high viral load, that you need to speak to them about condom use and contraception. But that's not for the reinfection issue. That's because we don't want it to transmit to negative partners, and we also don't want women of reproductive age to accidentally fall pregnant when they're not optimized in terms of their treatment and they're not virally suppressed. So it is still important to speak about condom use to avoid STIs, to avoid unplanned pregnancies, to avoid transmission from someone who has HIV to an uninfected person. And it's also important to integrate that contraception discussion. So to finish up, if someone has a once-off low-level viremia, which is a blip, you don't need to worry. Just put them straight back into their routine care. But if they have persistent, recurrent low-level viremia, be aware that it might be an early warning sign of adherence issues, and it might lead to resistance. And then actively manage that low-level viral load, just like you would if the viral load was over 1,000, because you're trying to stop them progressing to that point where they have a high viral load. So use your ABCD, provide EAC where it's relevant, and repeat the viral load after 3 months in an ordinary adult, but please do it after 1 month in a pregnant or breastfeeding woman. Check for your STIs, your other infections, your GIT issues, your drug-drug interactions, and take some time to make sure that it's not from occasional missed doses. And if it is, give good quality treatment literacy. It's not just about take your drugs every day and make sure that you are that you're swallowing your pills on time. That is not treatment literacy. You need to go into more detail than that. And then there's your algorithm on the side that shows you that the low level and the high level viremias have all been put into this definition of unsuppressed, and the management for those is the same. And then there was another poll, but I'm just aware that I've gone over time, so I'm not going to do that. I'm going to hand back to Kate. Thanks.
Great, thanks. Yeah, that makes sense. So without any more time going past, we're going to hand over to Tumiso then to take us through the case. The case is a really good one. It focuses very much on the topics that we've just discussed. So Tumiso, over to you.
Good morning, everyone. I'm Dr. Tumiso Masenya. I'm based in Region D, city of Johannesburg. So I've got a case here. It's a patient. It's a 41-year-old female patient. The patient was um, diagnosed and initiated in January 2020. She's currently not pregnant, and then she's currently not breastfeeding. She doesn't have any comorbidities. And then she was initiated on the current drugs, which is TLD, as you know, and then she has been on the same regimen ever since, and then she has never missed any of her clinic visits. And then when she was diagnosed in 2020, she was then initiated on IPT as well, and then she completed the regimen in March 2021. And then the other drugs that she's on, she takes vitamin B-co every morning at 8, and then she says that she sometimes feels dizzy, especially in the mornings, and then she easily gets tired. That is the reason why she is taking uh, this vitamin B-co. So her baseline CD4 count cell was 209, and then when I checked in the file, there was no a recent CD4 count bloods that were done. And then in January 2021, her viral load was 555. In February 2022, then it became suppressed. And then in January this year, and then it was back again. It was 181, and then they repeated the bloods again in October again, and then the viral load was 161, and then the renal functions, they are normal. The creatinine of 74, and the EGFR of 87, and then no any other bloods were done for the patient. And then she has never missed any of her appointments, and then the pill count was normal. So despite her feeling dizzy, she says that she has never missed any of her appointments. And then the only drug interaction that I could point out is that she's taking a vitamin B. So adherence counseling was done to her to actually make her aware that I had using over-the-counter medication. The over-the-counter medications are what could causing her not to have a suppressed viral load, and then um, we're gonna be seeing her again, I think, by early January again. All right. Thank you.
Okay, thanks so much. So I think the results and everything are fairly clear. I just wanted to understand, you're going to be seeing her again in January. And what are you going to do in January?
In January, we're gonna be repeating another viral load, and then
Okay.
we're gonna be also uh, uh, trying to check if the dizziness is continuing, and then if it's still continuing, then we have to check if there's any other causes by uh, investigating her thoroughly again.
Okay. All right, thanks. So then I will open to the floor for any questions or comments or discussion about how we would manage this case. I think so. One question that I have is, if she comes back in January, and you repeat the viral load and it's again like 150-ish, I mean, what would then be the next step?
I think the next step would be to go through the ABCDE again to see if she has any other causes like your bugs, and as we've seen on the presentation, we would have to thoroughly check any other over-the-counter or traditional medication that she might be taking. Yeah, and then if she has a current partner that maybe hasn't been tested, and then if she has disclosed to the partner and the family as well, I think that might shed more light
Okay.
as to why is she not suppressed.
All right. So, okay. So you don't feel totally confident that that has been completely done yet. I just wanted to check. I'm assuming because you said you're going to work up the dizziness in January, does that mean there hasn't been any kind of thorough examination or investigations about the dizziness? Even
No,
just
when I
a
check
FBC or anything like that?
in the file, it hasn't been done as well.
Okay.
I think she didn't disclose this to the clinicians that were seeing her. So probably that might still need to be done so that we can check if the dizziness is due to uh, mm, any hematological conditions or any of that.
Yeah. Yeah, I think that would be important. Okay. Natasha?
I saw Pretty had her hand up. Are you, because I like to hear from the floor first. Pretty, are you covered?
Yeah, good afternoon to all. Yeah, I wanted to check if like there were other investigations that were done to address the dizziness, because it seems like dizziness is a major concern other than the low Viraemia thing. So
Yeah.
I wanted to check if like other tests were done to exclude the cause of dizziness. And then again, I also wanted to follow up on the other factors that might have led to this client having a low-grade viremia, because I think maybe the issue of disclosure and the issue of other sexual partners to do the index, just to follow up and check if indeed we try to exhaust everything to address the low-grade viremia. Thank you.
Thanks. So I'll duck in my question here. I wanted to hear from the floor, how many of you have experienced clients like this who are fine on some of the brands of TLD, but complain of issues when they are on a different brand? Just if anyone would like to comment on that, and how good are we at hearing patients if they are saying they think it's the ARV and giving them a different brand. So I just wanted to hear any feedback on that and whether it's something you're seeing on the ground, because I think if someone is complaining that they think it's the ARV and we don't hear them and try and engage with them on it, then their adherence might drop off because they might feel frustrated that we're not listening, that they are complaining of a side effect. So does anyone want to comment on that?
DeCarlo, did you want to comment on that, or do you have another question?
Thank you, Dr. Kate. My question was still on the issue of the dizziness before
Okay.
Dr. Natasha came, but then maybe I should just shoot. I was asking maybe if we went deep to even check the sleeping pattern of our patient while she's complaining of the dizziness. I saw the time when the patient takes the medication, it's 14 hours. So maybe it might have an effect on the sleeping pattern and then translate to the dizziness. Thank you.
It's a good suggestion. And Tsetse?
Thanks. Thanks, Kate. Thanks, Dr. Natasha and Dr. Tumish. Yes, I think we do have some of the patients that would have that complaint, or I think what we usually do, we just attribute it to brand, because obviously they would explicitly say it, that when you use they will just say the color, and it will depend. Yes, it will. I think it will definitely drop the adherence, because maybe somebody who's taking their treatment fairly well would think, if I reduce, maybe I skip a day, that will take away whatever I'm feeling. But sometimes we find that we are in a situation in facilities wherein we really don't have a choice. For example, if at that time the blue container is wiped out, it's difficult to assist such a patient or a client. But it's something that we encourage as part of adherence, to talk to patients about the different brands that we have, that each and every time when I talk to clients, I talk about Checkers, ShopRite, the different the shops that you go to, and that it's a requirement that we need to shop around in those different companies. So just to say, at least that when they come across such, they might understand better, and just to treat that part of the side effect. But I think it's an important one. Dizziness is quite a heavy thing to have and to tolerate. Thanks a lot.
Thank you. And Sete, I was also thinking, you can easily imagine if someone gets dizzy or any kind of side effect, even if it's quite minor, you might miss a dose. And if your provider is not taking it seriously, you wouldn't necessarily want to disclose, oh yes, I didn't take because I had a thing today and I didn't want to get dizzy during the thing. Whereas if your provider is taking it more seriously and seems to be, listening to you, you might be more open to disclosing that you've missed. Natasha?
Yeah, I back that up. I think we sort of saw it with Aluvia, that for many years people would complain of the diarrhea and we wouldn't have another option. So we would just sort of try and normalize it and not realize the huge impact it can have on someone's quality of life if there's a side effect there. So I would really encourage you as clinicians that if someone is complaining of something, even though to us it might not seem that serious, it's important to say, I hear you and I can see that you're struggling with that. And quite often what I do, if I'm not sure if it's a side effect and it's not something that we know comes from the 3 ARVs, so it's not, tenofovir, 3-TC and dolutegravir are not known to cause dizziness. But for sure, remember that these 8, 9, 10 different companies that we are using who are producing the TLD are all using different chemicals in their components to create that tablet. So there are definitely patients who can be sensitive to side effects from the components, the powder stuff that is used to compact the medicines. So I definitely do have patients who have strongly reacted to Luvigen. And then when I try them on Ecryptega, they're absolutely fine. Put them back on Luvigen, the side effect comes right back. Now, it might be psychosomatic. They might have made a decision that Luvigen is bad for them. But the point is that if you keep giving them the Luvigen, they're going to eventually get fed up and stop taking it. So what I would suggest, in terms of sometimes you don't have an option, you only have one TLD in stock, is to see if pharmacists can keep a small amount of a previous brand, and only let it go if it's getting close to expiry. So you've got an option. And the other thing is you can give them Truvada and dolutegravir until another brand comes in. So remember, you could give them the split if they're very strongly saying that a brand is not suiting them. So that's something to remember, because I think it is a reason why you can get a low level of viremia is someone is just occasionally missing a dose because they're not enjoying taking this tablet. So thanks. Yeah, back to Kate.
Okay, thanks. So I've got a couple of questions for the floor. My first question is, and it's I know kind of, I think what the guidelines say, but so we've got this patient. They've had a viral load of about 150-ish twice now, and it was about a year apart. It wasn't 3 months apart. And now the plan is to repeat the viral load in 3 months at 100, in 3 months. You're going to do that viral load again. If it comes back at 100, are you going to bring the patient back in March for another, or April for another viral load? Okay, so I'm gonna call on people, I'm afraid, if we're not getting answers. So I'm gonna call on Salika. We haven't heard from Cape Town today. If you're listening, would you bring the patient back again? If their viral load in January is about 100, 200, are you going to bring them back again in March or April?
So hi Kate, sorry I can't put on my video, my signal's not that great, but
No
basically so in terms of that patient, January is part of the new year. If it was before December, I would wait a bit because we know everybody's away during that festive period. If it's about 100, what some facilities, well, what we could do is do a telephonic contact or a recall of the patient to ask them if they could come in for enhanced adherence counseling. Would only repeat the viral load in 3 months after they've had at least 1, 2, or 3 adherence counseling sessions. If they have been booked for an appointment in March, for example, this was the date given as part of standard care, and the client hadn't received any enhanced counseling sessions during that time and arrived again in March, I wouldn't repeat the viral load then. I'd do adherence counseling and then repeat the viral load 3 months after our adherence counseling. So it just depends if we've managed to be able to conduct some sort of intervention to alter the adherence pattern during that time. So in terms of if they come in January, we'd recall them, ask if they could come the next month just for a counseling session. They don't need to see a clinician. If they are, then we do 1 or 2, 3 counseling sessions before the next viral load. Yeah, I don't know if that answered your question.
Yeah, it absolutely does. Thank you.
Because I think what we do notice is these are the clients that are going to be struggling to come to the facility more often than usual. So you also don't want to put them off and completely inconvenience them and pull them out, let them fall out of care because you're calling them back too soon. So if we can do a telephonic one, we'll go that route as well.
Okay. Thanks. Anybody have any different ideas, or does that sound reasonable, Natasha?
Let's see if anyone else has a different response first, and then I'll just go. I just want to share with you the algorithm on the guideline, because it's quite interesting and a little bit ambiguous actually about the persistent low-level viremia. So is anyone else doing anything different? Because it's a very good question. So everyone is keeping them in a 3-month loop. No matter if they get 5, 6 low-level viremias, everyone is bringing them back after 3 months for repeat VL. Okay, so let me just...
Sorry to interrupt, Natasha. I just want to say, I can see Ntaba saying shaking your head, because we know that is not what's happening in general. Like, I know we are a different a group of clinicians here who are TAs and everything, but we know that on the ground that is not what usually happens, and we see so many patients with low-level viremias that don't get a viral load repeated, even if a case manager is asking the clinician to please repeat it, just to put that out there.
But so in terms of saying, do you agree that according to the guidelines they should stay in a 3-month loop, but it's not actually happening, or are you shaking your head because that's not what the guidelines says?
No, both. The guidelines say something like the first one can be 3 months, and then the second one something like 6 months or something like that. It's definitely not the 3-month loop. But also, even the first one sometimes is not even repeated, as Kate says. Even if they say it's 6 months, even that sometimes is not repeated. So yeah.
Yeah, so let me just pull up the algorithm for you guys. So this is the important bit here. Okay, so if the first viral load is anything over 50, you do your ABCDE and you repeat after 3 months. And then if it's still over 50, then and there's an adherence issue. As I understand it, you sort that out. But you see here, it says repeat the next viral load at the next scheduled routine viral load, which is in 6 months' time, not in 3 months' time. But it's a little bit ambiguous, because if someone is like 5 years on ART, their next scheduled routine viral load might actually be even longer than that. But what they are saying is that if you've picked up an adherence issue and the person has ongoing low-level viremia with 2 or more, then you can drop them into a 6-month repeat. But I think what's really important is that you don't push it to a year, please, because at the moment with dolutegravir, we don't know if this ongoing low-level viremia is a risk for treatment failure and emerging drug resistance or not. We just don't have the data. But in terms of how you think HIV works, and that every time it replicates, every time it makes a new copy, there's a chance that it's going to stumble across that right mutation that causes drug resistance. You can imagine that if someone has low-level replication for 3, 6, 12 months, there is an increasing chance that their virus, just by luck, will stumble across those mutations. So I think it would be absolutely justifiable to move to a 6-month repeat in someone who is constantly just bobbling along, but don't go to an annual. And with those guys, you can have them in the RPC, because what you don't want is to make it more difficult for them to stay on their treatment, and then their adherence goes down instead of improving. So these guys are complicated, because as a clinician, you get stuck with, it's not perfect, but I don't really have an answer as to why it's happening. I have a lot of patients with low-level viremia, and you go through everything in the A, B, C, D, E, and often you cannot find a cause at all. So then, I mean, I guess I'd like to ask, when you have those patients who are just stuck, you cannot find a cause, they're in a 6-month repeat pattern, how do you counsel them? What do you say to them? Because they're going to get despondent as well, and maybe not trust their meds because they're taking them. They say they're taking them, but their virus is not suppressing. So how do you keep them engaged so that they don't become despondent and actually their adherence gets worse because their blood results are not improving? What will you say to them?
Can I ask Jonathan Malicha, what do you like to do in this situation?
You have to go off mute to answer.
Hi, Dr. Trash. Yes, you caught me off guard there.
Sorry.
I think you need to reassure them that if they're taking, they're doing well, they must continue. But again, I think you also need to find out if there are other things rather than adherence that might be causing this viral load to really suppress, because you might find that there are other underlying issues that we're missing, which is outside the adherence part. So I think that's what I could go to try on. There are social issues. What is the situation at home? Are there other issues that they might be dealing with, more especially issues in line with poverty and because now you can tell the economy is tough. Those are the kind of things that I can look at. Yeah.
I think one thing that I picked up there, which I think is really great, is that you start from a place of believing the patient and encouraging them. I think that's probably good.
Yeah. And I think it's just about reassurance. So this low-level viremia is not associated with declining CD4 count. Okay, so the health in terms of the HIV becoming more advanced is not an issue. But one thing that we are learning in terms of people with any detectable viral load is that as soon as the virus is present at all, the person's inflammatory response turns on, and that can lead to longer term problems around these non-communicable diseases and the hypertension and the diabetes and renal issues and things. So you don't want to, if possible, you don't want to leave someone with a detectable viral load for long. You want to keep on looking for a reason. And one thing that I didn't put in the presentation because it's really complex, and I don't think the science is quite clear yet, but at the last 2 conferences I've been at, there's been a lot of talk about the HIV reservoir, which is where the HIV hides deep in the immune system. And what they're learning is that people who start treatment late and have had a high viral load for a long time before they start treatment, which is about a quarter of our patients, they have a very big hidden reservoir of HIV in their system. And sometimes because it's so deep in the immune system,
Have we lost Natasha?
level yeah. Sorry,
you just froze for a second.
Oh, okay. So this persistent low-level viremia can also be in some of the patients because they've got this massive hidden reservoir that is just slowly releasing little bits of virus. not related to establishing resistance because there's no drug pressure on those deeply hidden cells. So it's a very interesting concept, and I think it's something that we're going to learn more about over the next few years because people are really starting to study it. But it is, I think for me, what I do is I look back at people's history and I look back if they've had a period where they've had very high viral loads for a long time. And some of them really do. They started with a very low CD4, they had high viral loads, and they may have this ongoing low-level viremia because of that reservoir that they've built up. And then there's nothing you can do about it. You just need to say to them, it's okay, your drugs are working well enough, but we must keep a close eye. We're going to keep on checking your viral load every 6 months. We're not going to drop to it yearly because we want to make sure that it never goes above 1,000. And if they're always sitting less than 1,000, you can just continue reassuring them and saying their drugs are working well enough, and we'll keep them in the 6-month repeat. So I hope that makes sense in terms of being able to reassure patients that their health isn't going to be compromised if they have this sort of a very low level of viremia that gets stuck, and you as a clinician are stuck. You can't find any cause for it.
So I've got a question just as a non-clinician. So if we've got this case where the viral loads are very low, they're right on the bottom end of the spectrum, and you're kind of talking about as long as it doesn't go over 1,000. So if you had the same patient, but they were coming every 6 months with like a viral load of 600, 700, it wasn't trending upwards, but it's quite a lot higher than 100. Would that make a difference to how you manage them?
I think it would, because the more they're replicating, the more chance of them stumbling on those mutations. And we know that in some countries they use over 400 as the definition of rebound because of that risk. So the low, the like properly low, bobbling along at 100, 200, I wouldn't be worried. But if it's approaching 1,000, then I would think about maybe even trying to get a drug level and see if we're missing some absorption issue. Trying them on a different brand in case there's a side effect that they aren't communicating well. And yeah, so I think if I have a patient who's over 400, I tend to really push very hard to try and find a cause and to get them to resuppress. I'm sorry, it's not an exact science because it's these low-level viremias, nobody really knows. Some of them, they do just trundle along. Nothing happens, but they never suppress. And it's difficult as a clinician, it is.
Any other questions from the floor as we approach our time here?
Wanted to ask anyone their thoughts about her being female and 41 years old, if there's anything else you might discuss with her. Beatrice, what would you discuss with a 41-year-old female who's not virally suppressed?
Thank you very much, Dr. Natasha, and good afternoon, everyone. I think they've covered most of the aspects, like the sexual partners, and I'll also check if she's still sexually active and willing to maybe to conceive and all those. But what is mostly important is the issues of treatment literacy, just to show them what it means to be virally suppressed and the benefits of being virally suppressed. Because you get patients sometimes, but I'll also check if she does not abuse alcohol, because usually it's December and over the weekends, clients tend not to take medication when they go out to the taverns and all those. It might also be one of the contributing factor for this low level viremia, because usually on weekends you don't take, but during the week you take, so it can maintain the viral load at to be at the low level due to those kind of factors. So yeah, thank you.
Thanks. Katleho, won't you share your answer from the chat in case people aren't checking?
All right. Sorry.
Okay, don't worry. Katleho, I'll read it out. I can see you've got a complicated setup there. So Katleho suggested that in this lady, a pap smear would be a good idea, which, yeah.
Yeah, and good point, because she's 41. She started treatment 3 years ago. Her baseline CD4 was 209, so she was right on the edge of advanced disease. And now she's not virally suppressed, so she's got that chronic inflammation issue. So really important to check about pap smear coverage in all women. But if a woman is not optimized, really encouraged to get that pap smear done. And as Beatrice said, you want to discuss contraception. These early 40-year-olds are quite tricky because they often don't think that they need to be on contraception, but we see a lot of unplanned pregnancies in the 40-year-old ladies because they stop thinking about it, and condom use goes down because they're in stable relationships, and then boom, they have an unplanned pregnancy with not a great CD4 count and some active virus. So let's make sure that we're providing integrated services, and that as soon as you see a detectable viral load, you start thinking about the other things as well, the partner prep if they're negative, the pap smears, the contraception, all of that stuff, and the psychosocial support. Yeah, thanks.
All right, thank you. So I am going to wrap this up. I think that was a really interesting point. I know that it was the Joburg year-end function, so I just want to say a special thank you to Miso for doing the case today. We really appreciate it, and to everyone for joining on this Friday in December. We'd really like to thank you all for your participation in this project overall, but we still will, Dr. Louise will still be in the sessions next week. I will also share the link to the feedback survey via email so we can share it more widely. And there will be other components as well. We will be asking people next year if they would like to participate in an interview, just to verbally share some of your thoughts about what we can do with ECHOs next year. And there will be a slightly different way for hub members also, which is mostly the people on this call, to share frustrations, hopefully successes, and good stories as well with how they've managed with the platform and all of those things. So lots of ways for you to share your opinion. So please give it some thought. We genuinely are not sure what we're going to, how we should take it forward. And we want to hear from everyone to make the best plan for Anova. And after that long speech, I think that is it. Yeah, so see you all during the district echoes next week. Take care.
Thanks, everyone. If anyone who is presenting has any concerns about the slides or wants to reach out, please do before your session, okay?